In this part, we'll talk about the effects of different hormones. We'll also talk about the homeostasis of ions and pH levels, and then we'll end up discussing a couple of renal diseases. So first off, the renin-angiotensin system. Remember that renin is a hormone that is secreted by the kidney in response to low blood pressures. Renin converts a protein made by the liver known as angiotensinogen. It converts angiotensinogen into angiotensin 1. Angiotensin 1 is still inactive. It needs to be activated into angiotensin 2, and that occurs by the action of an enzyme known as ACE, or the angiotensin converting enzyme, found in endothelial cells. Now, angiotensin 2 is active, and it has an effect on the cardiovascular system where it leads to the vasoconstriction of the arteries. That increases our blood pressure. It also has an effect on the kidneys. Angiotensin 2 increases the levels of aldosterone and antidiuretic hormone. When we do that, we increase the sodium and water reabsorption. So eventually the blood pressure goes back up to normal. Angiotensin 2 also stimulates the thirst center in the hypothalamus, which increases, again, the water intake. Now, this is the effect of ADH when plasma volume decreases, meaning again that there is low blood pressure. So in hypotension or hypovolemia, that means that the pressures in our arteries is less than normal. That would be picked up by the baroreceptors. That will stimulate the posterior pituitary to secrete more ADH. When ADH levels in the plasma increase, it will reach the collecting ducts. So remember that the ADH increases the expression of aquaporins on the collecting ducts, and that leads to the increase in the tubular reabsorption of water. Now that we've increased water reabsorption and kept it in the body, that will help bring the blood volumes and the blood pressure back up to normal. Now the effect of the osmoreceptors and how it affects the levels of urine that we make. If we drink too much water, okay, that will decrease the osmolarity of our body fluids. That change in osmolarity is picked up by the osmoreceptors that are found in the hypothalamus. They decrease their charging, okay, they decrease their firing, and that means that the posterior pituitary will decrease the amount of ADH being secreted. Less ADH now reaches the collecting ducts. These aquaporin channels are going to hide back again inside of the cells, and that decreases the water reabsorption, meaning that more water is going to be left in the filtrate and more water is going to be excreted, leading to the formation of a diluted urine. A hormone made by the atria of the heart, known as the atrial natriuretic peptide, or ANP, it increases the excretion of sodium, and that you can guess that from the name. So atria means that it comes out of the atrium of the heart. Natriuretic means that it does help in the diuresis or in the excretion in urine of sodium. It is obviously a peptide hormone, and the stimulus for its release from the atrium would be the increase in blood volume. That stretches the atria of the heart, stimulates it, and that's the stimulus for the secretion of AMP. When AMP increases in the bloodstream, it reaches the kidneys that has receptors for it, and in the kidneys, it will lead to the dilation of the afferent arterioles and constriction of the efferent arterioles. Remember that in this scenario, that is going to increase the hydrostatic pressure in the glomerular capillaries, and that is reflected as an increase in glomerular filtration rate. AMP also decreases the plasma levels of aldosterone, so we will decrease the overall reabsorption of sodium from the tubules, which means that the sodium will remain in the tubules and will be excreted. So all of that sodium is now going to pull a lot of water with it. Okay, so remember this whole scenario started as increased plasma volume. So you want to get rid of all of that excess water. In doing so, you'd have to kick sodium out. Okay, you'd have to excrete sodium, and sodium will pull water by osmosis, as we know. Now, what about the effect of potassium on the kidney? When there is hyperkalemia, which is increase in the potassium levels of blood, that will stimulate the adrenal cortex to secrete aldosterone. Aldosterone will increase the tubular secretion of potassium in the cortical collecting ducts. Now for the regulation of calcium and phosphate ion secretion, well, that is mediated through the hormone known as PTH, or parathyroid hormone. When it comes to calcium reabsorption, PTH has really no effect on the proximal tubules, but parathyroid hormone does have an effect when it comes to calcium reabsorption from the distal convoluted tubules and the and the cortical collecting ducts. It will increase the calcium reabsorption from both of these parts. The effect of PTH on phosphate reabsorption occurs in the proximal tubule, where it decreases in the presence of PTH. Now for the homeostatic control of the pH levels, well, that is a function of coordinated effort between the respiratory system and the kidneys. Both of them we have to work together in order to maintain a normal pH level. The respiratory, the lungs, as we expire or as we exhale carbon dioxide, and we should know how carbon dioxide can be translated into acidity. If, for example, if we're in a case of acidosis and we want to eliminate more acid, we can hyperventilate, and in doing so, we are washing away excess carbon dioxide. That is a buffer system that happens within minutes. But let's say the cause of acidosis is actually maybe due to something going on in the lungs. Well, then the kidneys would have to buffer all of that excess acidity. And that process, though, takes a longer time to happen. It usually happens in hours or even days. So the buffering system of the respiratory center, or the respiratory response, is much faster than that of the kidney response. But again, if the cause is due to respiratory disease, well, then the kidney would have to compensate. And vice versa is true. If the cause of the pH imbalance is due to kidney disease, it would be up to the respiratory and the lungs to maintain pH balance. Here you can see different conditions, and this is copied from your textbook. I just added here like a little bit of scenarios to kind of relate this to clinical things and things that you might see out in the field. So acidosis means that there is a pH level less than 7.35, meaning that there's either too much acid accumulating, too much carbon dioxide accumulating, or there is an increased loss of bicarbonate. So we'll talk about respiratory acidosis versus respiratory alkalosis. And alkalosis would be where the pH levels is above 7.45. So we'll talk about a scenario first in respiratory acidosis. For example, in the case of pneumonia, where carbon dioxide is having a very hard time to get eliminated by breathing, because pneumonia leads to a thicker respiratory membrane, and it is now harder for exchange of gas to happen. So carbon dioxide is accumulating in the blood. So to compensate for that, okay, there are changes that happen in the bicarbonate level, and that is due to the renal compensation. So the kidneys would have to maintain that balance. In the case of respiratory alkalosis, for example, in hyperventilation, during during anxiety or during a panic attack, that hyperventilation washes away a lot of carbon dioxide. So your main cause here would be the wash of carbon dioxide, the low levels of carbon dioxide. That is your primary abnormality. And the kidneys would have to compensate by increasing the tubular hydrogen secretion. Now, if acidosis or alkalosis happen due to non-respiratory causes, we are going to name those metabolic acidosis and metabolic alkalosis. So metabolic acidosis, for example, in the case of diarrhea. So the intestinal contents are mainly alkalinic. So in diarrhea, where we lose a lot of alkali or base, that leads to where the acid is now relatively higher than the base. So you'll find that the loss of bicarbonate or low bicarbonate ions, that is your primary abnormality. In order to compensate for that and to, kind of wash away that extra, all of that extra hydrogen ions, we will start hyperventilating. Okay, so you see here the reflex ventilator compensation. So again, the hyperventilation that happens because of diarrhea would be in order to maintain that balance. Metabolic alkalosis scenario would be, for example, in vomiting. When we vomit gastric contents, which are mainly acidic, we have lost all of that acid, and now we only have, our kind of pH balances towards the alkalinic side. So your primary abnormality would be these relatively higher levels of bicarbonate ions. In this scenario, though, the respiratory rate will go down. Okay, so you'll see that there's the reflex ventilator compensation, where we want to accumulate some carbon dioxide in order to balance the increased levels or the relatively higher levels of bicarbonate ions. Now, a couple of kidney diseases that affect the body could be something affecting the kidney itself, like, for example, a bacterial infection, or it could be a systemic disease that can lead to complications in the kidney. For the most famous of our hypertension and diabetes. End-stage renal disease is one of the leading causes of death, and as of now, the only treatment for it would be a renal transplant. Before we get to that process of renal transplant, the patient goes through hemodialysis, and this is just a very simplified idea of what hemodialysis is, where basically the blood is pumped out of the body, obviously not all of the blood, okay, so it's takes hours for this to happen, but blood would be pumped out of the body, passed through an anticoagulant. You have to put some anticoagulant in there or the blood will clot. And then it'll be passed through this dialysis tube. The dialysis tube has lots of filters. There's a dialysis fluid that would be in there, and there will be exchange of chemicals between the blood and between that dialysis fluid. The dialysis fluid will be filtered out, will drain out, and the dialysis tube would also be hooked up to an air trap in order to detect and trap any air bubbles. And then it would be warmed up and inserted back into the body, returned back through the venous circulation. Two different ways of doing a dialysis. There's a hemodialysis, and that's basically what we just kind of explained. The other, it does have some limitations. Well, first off, the patient has to stay there for hours in order for this to happen. Not everybody has that kind of time or is willing to do that. So there's a more portable option known as the peritoneal dialysis, where the dialysis fluid is inserted into the peritoneal cavity, and the peritoneal membrane acts as the filter. Okay, and the patient would be hooked up to a drainage bag in order to drain the now dialysis fluid that has all of the waste products. So again, this does have its own, cons, that some patients do not want to move around with a dialysis or a dialysis bag or a drainage bag hooked up to them. So this is something, these are different options for different patients. Not everything would work for everybody. There is a website that you can go to learn a little bit more about kidney failure if you're interested. And I believe this ends the chapter, and we have reached the end of the course. I hope you guys enjoyed it as much as I did. And as usual, let me know if you have any questions.